Hello and welcome. I am Cyril Stover. The National Health Insurance Scheme commits to providing easy access to health care for all Nigerians at an affordable cost. Now, since becoming operational in 2005, that's about 17 years now, it has approached this goal with some measure of success, albeit maneuvering through a maze of challenges. Today, we revisit the scheme under the leadership of Professor Mohammed Nasser Sambo, a fellow of the West African College of Physicians. Now, a professor of health policy management, Mohammed Nasser Sambo is a pioneer staff of the NHIS who left at some point to continue a career in academics and later returned in 2019 as Executive Secretary. Professor Sambo, it's nice to see you again.
Good afternoon, Cyril. Thank you for having me today again. Thank you.
Right. Well, the last time we examined the NHIS and its programs, you had just resumed office as the Executive Secretary, and you spoke about 3 areas you'd be concentrating on. If I recall correctly, you talked about restoring the value system of the NHIS, engendering transparency and accountability, and you also said considerable attention would be paid to accelerated universal health coverage. How far with those goals? Let's begin with restoring the value system.
Thank you very much, Cyril. If I may put it appropriately, when we came, we unfolded a rebranding agenda, which has 3 pillars, as you have rightly put them: restoring value system, engendering transparency and accountability, and accelerating the drive towards attainment of universal health coverage. When we unveiled the 3 rebranding agenda, we brought in elements, because any agenda, you have to deconstruct it to bring out the elements. Then you now see how far you will go in implementing them. So for the value system, we gave a history of health insurance, NHIS being a very problematic organization in terms of governance and leadership. And I alluded to the fact that by 2019, when I came on board, there were 11 chief executive officers before me. So the organization was very unstable. It lacked internal cohesion. There was total lack of confidence, loss of confidence in the organization by almost all the stakeholders. So the value system was aimed to engendering, making NHIS to be a credible, result-oriented organization, and to put in mechanism in place that will do away with all the negative characteristics of the health insurance. And we are able to achieve that by the peace that has been restored within less than 1 year of our stewardship. And we have been able to look at other elements within the internal system of the health insurance that has to do with human resource, that has to do with financial resource, that has to do with adherence to due process, that has to do with even the rights of staff within the organization. For example, from the structural angle, we realize that activities of the National Health Insurance Scheme that has mandate of covering the entire Nigerian was concentrated within the center, within the headquarters of the National Health Insurance. 40% of the staff, as I said then, were within the headquarters of the National Health Insurance Scheme. And most of them have no healthcare background. And we had a lot of challenges, because if you look at the business process of the National Health Insurance Scheme, it has to do much with accrediting healthcare facilities, basically interface between the provider and the enrollees. And for you to bring a healthcare facility to operate within the National Health Insurance, you need to accredit the healthcare facilities, you need to accredit the HMOs, you need to do what is called quality assurance within the healthcare system, and ensure that the right things are done to the patient. And you need to do a lot of reconciliation to ensure that the system is not abused and misused, and so on and so forth. And if you look at the totality of this function, it will require some level of complement of healthcare professionals to handle it. Of the 1,400 staff that we met in the in NHS then, only 46 were healthcare professionals. By 46, I mean the doctors, the nurses, the pharmacists, and the medical laboratory scientists. And most of them were concentrated in the headquarters. If you want to do an accreditation exercise in, say, Kebbi State, you have to pull out this healthcare professional to go to Kebbi, and you have to pull them again to go to Bauchi, then you move them to go to Edo, then you move them to go to Bayelsa. Few people doing a lot of so there's a lot of stagnation. There is a lot of inefficiency, and because they cannot be able to handle those activities, they have to be combined with other people who have no background in that area. So when we had the interview the other time, I told you that we are setting out to recruit healthcare professionals, that we were setting out to do a decentralization policy, which will allow
more people to. So to what extent have you been able to do that?
We have been able to now decentralize our system. Now we have made our state offices very functional, which was hitherto not tenable. By functionality, we now deconcentrate the activities to be those activities that can be handled at the state level. They don't have to come to the headquarters. And we have been able to recruit 5 healthcare professionals in each of our staff offices. Then we recruited a total of 190 staff, 2 doctors in every state, 1 pharmacist, 1 lab scientist, and 1 nurse. So these are now the foot soldiers at the state level that are moving into the state healthcare facilities to carry out those functions that is supposed to be handled by them. And just mere introducing them into the states, a lot of things are beginning to change in terms of doing the right thing with respect to accreditation. In fact, a simple thing that we have done in the decentralization system is ability to use our decentralization system to recover a lot of funds that were being owed by HMOs in the past. When we came, there were a lot of complaints by HMOs, by healthcare providers, that they are being owed by HMOs. So we now employ, in the past, you have to send people to go and do what is called reconciliation, each state by state. So with the decentralization system we have done, we have been able to recover about 2.3 billion that is being owed by HMOs to the healthcare facilities using a decentralized system. So these are some of the internal things that we have done, and we have embarked on in the past. There is no career line in the National Health Insurance Scheme. If you are a doctor, if you are a pharmacist, you can be in Human Resource Department. If you are a doctor, you can be in Finance Department. That is how bad it was in terms of having not career pathway for every staff. Now we have been able to streamline that. Look, every system has a career line. If you are a financial officer, accountant, business administrator, or economist, and you are in health insurance, we now ensure that you are within the career path of finance and audit, as the case may be. Okay. If you are a healthcare professional, you will now be in a balance of in the area of operations, whereby you can grow and perform optimally. If you read humanities, you now go into the area of HR or informal sector, where we feel you can grow career-wise and develop, so that if for adventure you are leaving NHIS, you would have muster enough experience to be moved into another organization and fit successfully.
All right, that's as far as the staff and the repositioning the NHIS is concerned. But let's come to the other side of it, and this time the question of the enrollees. First, let's look at who is covered now. It started off targeting just those in the public service, and even that, the figures were on the low side. So now, who is covered by the NHIS today? Can we look and see has access or coverage improved?
It has, in the last 2 years, it has improved significantly. Why I say it has improved significantly, if you look at the matrix of cover before, NHS covered substantially the federal government employees. State governments employees are not within the National Health Insurance Scheme. The informal sector is said to be there, but it's not, it was not functioning because the framework for bringing the informal sector was not there. Then you have some sporadic community-based social health insurance scheme that even the literature, if you go through the literature, they are very volatile and unsustainable because they cannot be able to bring about the necessary fund and pooling that is required for the health insurance. So looking at what has changed ever since I came as Chief Executive Officer, we have been able to introduce what is called gift-ship program, Group, Individual, Family, Social Health Insurance Program. This is a platform that we've created to allow individuals who have the means of joining the National Health Insurance Scheme, but they are not working in either private sector or government sector. So now, as an individual, you can come and join the National Health Insurance Scheme under the gift-ship program. Also under the gift-ship program, a family, a husband and spouse and children can come together and join the National Health Insurance Scheme as a family. And many families are now joining. Then under the group aspect of the social health insurance, we have associations, we have organizations, we even have people that can help other people to enroll into the National Health Insurance Scheme. So we now have a situation whereby group of people, for example, group of lawyers in Nigeria under the auspices of Nigerian Bar Association, they have come as a group to enroll into the National Health Insurance. This is a very good omen to the organization, because if the learned society, if the learned group will see the merit of the health insurance and come and join it, then it's a matter of time others will come. Then other group.
Okay, because I was going to ask, what about a vulnerable group that is most times overlooked? Retirees and pensioners of the federal government.
Yes, I'm reeling out the groups. So if you had allowed me, I would have come to that. The vulnerable groups, the retirees. The Honorable Minister of Health also recognized the need in line with President Muhammadu Buhari's agenda of mandatory social health insurance scheme. He established and constituted a committee on retirees. There are two types of retirees. The retirees that have worked in a government and they have retired, and there are retirees of private sector. Then there are other group of people that are similar to retirees, which are the elderly. So the Honorable Minister of Health has constituted a committee to see how we can bring retirees and elderly into the National Health Insurance Scheme. And the committee is chaired by former Permanent Secretary of Ministry of Health, Linus Awute, which has a lot of membership from PENCOM, from Office of Head of Service, and so on and so forth. The whole idea is, how do we provide healthcare services, health insurance for retirees? Retirees, that committee has tried to categorize this retiree as I told you. There are retirees like retired permanent secretaries who retire with their pension. Therefore, they have substantial amount of money which you can take premium from. There are retirees that their pension is taken to PENCOM, And that is why the PENCOM is part of that conversation, so that the committee will now look at it, because health insurance, Cyril, is not free. It has to be paid for. So if you have a retiree, somebody has to pay for him. Either health insurance, either you pay it yourself or you have somebody to pay for you. So within the ambit of their pension scheme, is there opportunity that we can, some proportion of that money can come to the national health insurance?
Yes, and we're looking at, since the fact that the retirees and the pensioners, most of them now, the income is sometimes a quarter of what they used to be. So even if they were enrollees in the past, now those resources cannot be the same. You take that into consideration? Absolutely,
because as I said, you see, the health insurance, either you pay, or somebody is to pay for you, or you pay part, somebody is to subsidize for you. So by the time the committee finish its work, the arithmetic will be done to see how many, based on their pension, how much can we recommend that it should be paid into the health insurance, and how much can possibly government come into the subsidy, because you have to do that arithmetic. If you want to go to the government to seek for any intervention, you have to do your homework, so that you now talk with fact and figures. So that is what the committee is doing. So there are so many options. The retirees that their pension can take them to pay premium to continue to enjoy health care services, will recommend that they should continue to pay. Retirees that can partly or partially fund their health insurance, we can recommend that government should give them subsidy. When the retirees that are in the part of vulnerables, then they can benefit from the subsidy vulnerable program of the government. I want to use this opportunity to tell you that under the National Health Act, there is what is called Basic Healthcare Prohibition Fund. I think I mentioned it the other time I was here. The Basic Healthcare Prohibition Fund is a mechanism of funding healthcare for the vulnerable groups. 1% of the total consolidated revenue is supposed to come to the national health system, out of which 50% of it comes to the National Health Insurance Scheme. And that 50% is not administered by the National Health Insurance. It is distributed to the state health insurance agencies, because those states are very closer to the people, and they can use their local government structures and community structures to bring those who are vulnerable and register them and benefit from the healthcare services. This is one of the programs that we must give credit to the President and the Minister of Health, by ensuring that there is a funding stream for that. However, that funding is not sufficient enough to cover the vulnerable segment of the population. If you go by the World Bank report of 2000, it says that over 80% of over 80 million of Nigerians are living below poverty line. So if you have a situation whereby 80% of the are living below poverty line, that means those group of people cannot be able to pay for their own health. And therefore, one of the functions of the state is to see how can these people be financed through innovative financing. Health insurance is a very dynamic organization that is supposed to be thinking on strategies of mobilizing resources in order to cover people for healthcare. And like you, the universal health coverage, that is the Sustainable Development Goal, has advocated that there is under Goal 3, it says that people should have access to universal health. So it is a universal global declaration. And therefore, since we are very much aware that not everybody can afford to pay, then policies that can bring about funds to finance this health insurance system need to be supported by all and sundry. We have made a proposition of 1 kobo per second call from telecommunication to come into the healthcare delivery system. I think this is one of the most seamless, innovative financing that we can have in this country. Other countries have practiced it. Many people across the globe now use their handsets. And if you look at the amount of money that people are spending in their handsets, it's even more than the amount of money that they use to feed themselves.
Right.
So if you take only 1 kobo per second and you put it into the healthcare, the person that you have removed that 1 kobo call from will not feel it.
Okay.
And this has capacity to bring about billions of naira that can be used to cover the vulnerable. We have worked with the National Assembly to ensure that that is encapsulated in the proposed amendment of the National Health Insurance Bill. But we have been corrected that it cannot be in a sectoral bill. You cannot make that inclusion, because only through financial act that such kind of things can be entertained. So
where are we now with that proposal?
Where we are now in the proposal is that we are amending our law so that it can be mandatory, because it's one of the major limiting factors to penetration of health insurance. The bill has been passed by the National Assembly. It is to be transmitted to the presidency. That is after that observation. Mm-hmm. But so we are going to work with all the stakeholders to continue to generate a momentum that will make the finance and other policymakers to see the value of investing in health, so that amount can be given to the health insurance to cover the vulnerable.
All right, that's expanding the scope and bringing in more people under the coverage. But now let's go to the individual basis. You talked about the rights of the staff of the NHIS. Now let's talk about the rights of the enrollee. Who is already on this scheme? What are they entitled to, and under what terms and conditions?
If I remember vividly, during our last interview, I have informed you that we are developing an enrollee book, which will spell out the kind of coverage that is within the National Health Insurance Scheme. And I've also informed you that it will give us the range of the drugs that enrollees are entitled to. So, and we have been able to do that immediately after that interview. Right. We have uploaded it into our website so that anybody who is there, we have even developed a pamphlet. I have forgotten that I should have bring some of the pamphlets to you for further education. But we have been able to do that. Now we will have a pamphlet which spells out all the enrollees' rights and spell out in terms of services that they should receive, and in terms of the drugs that they are to receive at the level of primary health care, and when they are referred to the next level of care. We are aware of a lot of problems that a lot of complaints from the enrollees. This is very known to us. One of the major problems that I met in the National Health Insurance Scheme, there were no microstructures within the organization to deliver some specific tasks of the organization. What do I mean? In the guideline of the National Health Insurance Scheme, it prescribes that there will be a sanction for any healthcare facility or for any HMO who has erred. So what is the mechanism? How do you detect those things? And how do you get the people that have committed such offense? And what are the mechanisms in place to ensure that the prescription of the law or of the guideline is meted against the area? Those structures were not there. These are some of the weaknesses that we are working assiduously to correct. With respect to aggregating the complaints of the enrollees, we have because the complaints has become a recurring decimal. We do a very strategic pursuit of the process, because when you come and meet an organization that is so weak, the foundation is very poor, you have to do a lot to solidify the foundation. What we try to do is to ensure that we reconcile the healthcare providers and the HMOs. And we were able to retrieve a lot of funds for the healthcare providers, as I told you.
Right.
Now the healthcare providers are smiling that they have recovered some substantial part of their money. Then we now say, okay, the turn is now your own for you to be responsive to the teeming enrollees. And we developed a very small, simple criteria. The other time I came, I told you that we are doing an overarching state-of-the-art infrastructure, developing a state-of-the-art infrastructure with respect to digital transformation. We have received federal executive approval, and we have now been able to finish all the installment of the infrastructure that is needed. What is left for us to completely automate our process is to now have a handshake, interoperability between the National Health Insurance Scheme and all the stakeholders, the HMOs. Part of this ICT infrastructure, there is what is called call management system, whereby wherever you are in Nigeria, in any healthcare facility, you have a complaint, there will be a toll-free line which we have already secured. You just make a call. We will place all those calls numbers in every healthcare facility, so that once you have a complaint to make as a result of process of receiving care, you can make a call. We have a very big MCC, monitoring control center in Abuja. The call will hit that MCC, and it will now be routed to our healthcare providers that we have employed, who will now receive those complaints in a given healthcare facility and quickly connect with the desk officer in that healthcare facility that Mr. XS, who has NHIS number from a particular hospital, has come to the facility. He has denied a given drug which is in the list of the of the NHIS drug list. So if we now, then we expect you to take a remedial action. If you take a remedial action or you refuse to take a remedial action, it's going to be recorded. So at the end of the month, our healthcare personnel that are working at the state level will aggregate, because there is a format which complaint will be received. They will aggregate the complaints from every healthcare facilities, and they will now designate a facilities that have crossed a red line.
Right.
If a facility crossed a red line for the first time, that facility will be given warning. Next month, the process will repeat itself. If the same facility cross a red line again, it will receive a yellow card. If by the third time that facility cross another red line, that facility will receive a red card. And what is the implication?
Exactly.
The implication of the red card is to take all those enrollees in that healthcare facility to another more responsible facility, so that enrollee, that healthcare facility will no longer. It's obvious that he cannot take care of the health insurance enrollee. That is a mechanism we have just concluded, and for it to be implemented, we need to enlighten the healthcare providers.
How soon are we looking at this facility going into operation?
Yeah, anytime soon, because we have just finished sensitization of a meeting with the healthcare providers, and we have unveiled that system to them so that they can critique it and they can make input into it. Because the new NHIS, we say that we respect the views of stakeholders. So we have finished with the general healthcare providers. We are also trying to explore to meet with the committees of CMDs and medical directors so that we give them this information. And for the total operation of this system, I told you that our ICT digital system has to be working. But because of the importance of this system, we don't want to even wait until when the ICT infrastructure is launched. We will do we will circumvent the call management center to now have in every healthcare facilities the the number of the doctors, of our doctors in
Right.
our healthcare facilities, so that you can come directly. And once we are able to conclude with the ICT, then it will migrate spontaneously.
One of the commonest complaints by enrollees when they go to access service in care providers is, one, to do with prompt attention, two, the issue of drugs, which you have just mentioned, and what is covered under the health insurance scheme. And of course, as you would by now know, one of the other complaints is that they go to a health facility and the first thing they are asked is if they're under the NHIS or if they're paying. Now, ordinarily, that would seem quite in order because you want to know where you're challenging it. But on the other hand, what that leads to is the minute NHIS is mentioned, then that becomes, you know, a level, as one step lower in terms of care and the kinds of attention by health professionals that you see.
Yes, these are the complaints that are coming from the field, but it's not true. It doesn't have a universal application. Of course, there must be a triage in hospital. Are you NHIS? Even in Abro, when you go, are you NHIS? Do you have health insurance? Then they will now put you on one side because you are not expected to make a payment. If you are not NHIS, you have to make a payment and so on and so forth. So it has to be clearly delineated.
That's the way it should be, but it's been it was used as another form of discriminatory access.
I don't think so. I want you to just visit Garki Hospital that is just close to us here. I don't think if you will see that kind of discrimination. And in fact, if you go to Garki, more than 40% of their clientele are health insurance. In fact, health insurance is a major NHIS, and more than 50% are health insurance, including the private. So it's not in all the healthcare facilities. Some of the healthcare facilities are frustrated with health insurance, and the reason is not far-fetched.
Okay.
For you to be able to thrive better under the National Health Insurance Scheme, you need to have the number.
Okay.
Some of the healthcare facilities don't have the number. Therefore, they get frustrated.
Right. Then there's this other aspect of it, which we would like you to clarify, because this issue comes up again and again and again. It's related to drugs, the kinds of drugs prescribed. There has been, it's a long-standing issue about generic drugs or those branded drugs. There's a tendency to see that sometimes the drugs that are recommended, which are generic, are considered as less efficacious and probably cheaper, and so that's why it is. There's always been this argument. Would like you to clarify now the question of branded drugs and generic drugs, and what's this whole thing about it?
Thank you very much. There is no interview that I will attend. This question will not come. And I'm happy that we're on one today so that we can inform and educate Nigerians. And I want, after this program, the NTA should do a special program of enlightening the people about the fact that the branded drug and generic drug are one and the same thing. When you manufacture a drug, it is the process of developing the pharmacology and pharmaceutical chemistry of processes of developing the drug is such that at the time when you are producing a drug, it's a combination of chemical compounds. So by the time you produce a drug, it has a chemical compound name. That is its original name. And when a company decides to produce that drug, that same drug, with the same chemical compound, it will give it a name, so that by that name, you identify the company. So if we produce a paracetamol, which is the chemical compound name, and a company produce it, they will give it Panadol, the name Panadol. Another company will give it Capdol, and so on and so forth. So there is this notion that a branded drug is superior. But because of the pharmaceutical industry, when you now brand a drug, it becomes more expensive. But the chemical content has not changed. People need to understand that because you branded the drug in the name of company, does not mean that the chemical compound of the drug has changed. So therefore, when you have a drug, whether it is in generic form or it's branded form, is just take it that, well, you are taking this drug because this is the company that does it. But in terms of composition, it is the same thing.
How did we get to this situation? Because lots of people have spoken to who are still worried about these generic and branded drugs. Their argument is that, well, at least with the branded ones, we know who, even though this is a matter of a company name, we know who to hold responsible if we feel that this is not. But in the case of the generic, and you can't really tell, these things may be handed to you in packages that are not branded, and you do not really know what you take in. How do you explain that?
You can tell because no company is allowed to produce a drug without certification of NAFDAC.
Okay.
So the fact that drug is put in a tablet in a sachet for you or in a leather for you does not deny the fact that that drug is a product of a particular company, and that company must have been certified by NAFDAC. If any drug is not qualitative or is not a genuine drug, that's responsibility of a sister agency to fish it out.
Right.
That's why we have structures within our health system that are supposed to monitor and track those drugs that are not.
Okay. So for all those enrollees who worry about being given prescriptions that from generic drugs, they can rest assured that these drugs are not
absolutely.
Not, I mean, inferior.
They are not
quality.
inferior. It's a mental thing. If you go to, even we that seem to be educated, if you go to a particular market and this product is expensive and this is low, you won't even waste your time to check out the quality. You'll take the expensive one because it's a mindset, and that mindset has to be. But Cyril, we need to, as a responsible agency, we need to respond to the complaints of the people.
Right.
And we have not just folded our arm to say that, okay, since we are sure that generic drugs are the same with the branded drug, and we just allow the complaint to go on and on and on, because even if you mount the most strongest advocacy or sensitization, people will not. Some people will not still accept that fact. What did we do, or what are we doing? We are within the National Health Insurance Scheme because this is a major source of concern to us, and secondly, that is the quality of drugs that is being dispensed, and people are not happy with that generic drug. Secondly, the cost of drugs, because of our economic reality, are in upward trajectory. Right. So what do? We now sit down at the level of our management and agree that we need to come up with innovation. An innovation that will bring about a situation where we have drugs cost coming down, and a situation where we will address this issue of generic drug within the National Health Insurance ecosystem. So we now brought all the stakeholders, the Drug Manufacturers Association of Nigeria, PGMAN. We brought in the NAFDAC, we brought in the NIPRIT, we brought Custom, we brought Ministry of Industry, all the stakeholders that have any relationship with the process of manufacturing and dispensing of drug, to say that the NHIS wants to borrow a leaf from what has happened under PTF. under PTF, you have a situation whereby drug and commodities, health commodities, are being branded with PTF inscription.
Right.
And that system was used by our president then to bring about a lot of availability of drugs of good quality. And anybody that has been in Nigeria knows the potency of that PTF system. So we now agree to develop a system whereby we can also use that system to brand a drug with NHIS inscription. We took almost, because of COVID interruption, we took almost 1 year discussing as the level of committee. We brought in commissioners of health, we brought in healthcare agencies, we brought in Federal Minister of Health on how to be able to do that branding of drug. After a long conversation, we now agree that manufacturers agree that they will do a branding of drugs for us, and they will bring the cost down, and wherever you go as an NHIS enrollee, you will see a drug that is branded with NHIS. And if you see that branding, you know that you are sure
quality control.
It's not a fake or substandard drug. That process has been concluded.
Okay.
Federal Minister, our Honorable Minister of Health has approved that concept. And now we are going to advertise because we need to quantify what will bring about the cost down. Is ability of a company who is manufacturing 10,000 X drug. Now, because they are in NHIS, they can produce 10,000 X drugs. The scale of quantity will now apply. So the companies have agreed. In fact, we have gotten into, we have signed a memorandum of understanding with Roche to bring down cancer drugs. And based on the memorandum of understanding we have signed in line with this idea of branding of drugs, Roche has agreed to manufacture latest drugs, latest anti-cancer drugs, and they will subsidize the price by 50%.
Speaking of which brings us to the question of the drugs covered under illnesses covered under the NHIS, and there's still a lot of people out there who believe that anything to do with cancer is not covered. It's
not correct. That's why people should avail themselves with our guideline, with our package. What was very obvious, because at the time when the drug list was done, some of the drugs, there has been advancement in some of the anti-cancer drugs. We are not covering cancer wholly because we don't have the fund to do that.
Right.
So, but we have a partial coverage with anti-cancer drugs. So when we look at the drugs, the major complaint was that there are newer drugs in the market for cancer. And those ones in the NHIS drug list are older drugs. Right. So now through this collaboration with
updating?
Yes, the Roche will manufacture the newer drugs for us, and they will subsidize the cost by 50%. NHIS will now be paying 30% of that drugs. Then the enrollee will pay 20%.
Right. When you talk of partial coverage under this, let's expand it to clearly state what can an enrollee expect if they go to a hospital and it turns out that there is an issue of cancer. What can the enrollee expect?
Yes, you see there are so many management line of management of cancer.
Right.
There are chemotherapy. That's a process where you give drugs for the treatment. There is radiotherapy. Some of the cancers are radiosensitive. There are also places for surgery where you enter and cut the tumor or the cancer. So depending on the cancer and depending on the regimen, the partial coverage will say, because the NHS fund, without this innovation, the existing NHS fund cannot say to cover the entire cancer. If you are to go for a chemotherapy, for example, maybe say 4 courses, NHS can take aspect like say 50% of the courses that you will undergo. Then you also have to pay for the remaining 50. That's the kind of partial coverage. We are not doing it wholly, but with collaboration and bringing down the cost, we are hoping that the cost will come down to the level that NHS can say to cover it. But you know, in the health insurance, the amount of fund that is available within the health insurance fund is what it is to be used to purchase health care. And this is one of the basic principles of health insurance anywhere in the world. You have a very large fund because your salary is good, the premium you are paying is good, then you will have a very large benefit package. If the salary is small, the premium you are paying in turn is small, and you have a small fund, it will cover a small benefit package.
And then, but sometimes, unfortunately, life doesn't work out like that. The guys with a very small benefit package are struck more times by ailments. And they are the ones who cannot afford, who really cannot afford the cost of that.
It's an economic reality which is applicable to every sector, Cyril. Will you tell me that everybody has opportunity to have 3 square meals in a day? Is food not essential?
So let's look at the social aspect here, because for the well-to-do, they can afford, but for the people who are down there, I mean, having ailments can sometimes mean end of the road, because that's why health is a social service. Health is supposed to be substantially social service, which should be highly subsidized. And if you don't do that, where else? Exactly. One of the other challenges the scheme has faced has to do, we've talked about a bit about the NHIS itself, the enrollees, the healthcare providers. Now, the HMOs. How have you been able to sort out the huge arguments back and forth of the real aim of these HMOs, and have you rationalized the number of HMOs? What have you done about this situation?
Yeah. You see, we came at a point when the president is talking about due process. You follow due process in whatever you do, no matter how overzealous you are. You shouldn't go and do something that is outside the tenet of rules and law and order. When I came to the National Health Insurance Scheme, you made a mention that I was in health insurance before NHIS. In fact, as a matter of fact, I was the one that established the Southwest Zonal Office in Lagos when I was a young man. The issue was, there is a law that establishes NHIS, and there are guidelines for operations. So when I came, and incidentally, in my last sojourn in NHIS, I was the one that was heading HMO division that registered the first 5 HMOs. So I know
the issues at your fingertips.
I know the laws, I know the rules, and I know the regulations. The first stakeholders meeting that I have done to them, I say, look, there are so many schools of thought with respect to the HMOs in health insurance. Some countries are operating health insurance without HMOs. Some countries have HMOs. But our law has provided that there should be HMOs. And I cannot single-handedly hit to those people advocating that HMO should not be until when the law is changed. Therefore, the simple thing that I am soliciting is that we play the rule according to the game, because there are rules. And I believe that if the rules are adhered to, there should be no cause for complaint.
If they play the game according to the rules, that is.
Yes.
Where they don't. And given the level of accusations against the HMOs and what they stood for in the past, Has that changed?
Where they don't apply sanction, and that's exactly what we did. For the first time in the history of the National Health Insurance Scheme, we had delisted 10 HMOs who have not been able to heed to the simple rules and regulations of NHS.
Now that is what the public wants to know and hear about, and so they can say, look, those who are not performing up to expectation will have no place in the scheme.
We have delisted them, and we are ready to delist any HMO who has failed in meeting his obligation. That's why we are putting all these structures. And that's why in putting these structures, we are not doing it along so that it will not be like a military system. We are dialoguing, we educate them, we inform them that this is a problem. We don't do things without diagnosis. And we don't, in fact, one of the cardinal elements in our second pillar of rebranding, engendering transparency and accountability, we have 6 elements. We say we will work with evidence, working with evidence. Whatever we do, we ensure that we do a small study and bring out facts and figures. And we have institutionalized quarterly meeting with HMOs where we discuss the problems, challenges, and ways to propose solutions. So what we try to do is, when we have a problem, we investigate it. In fact, now we are bringing professionals to come and look at some aspect or some operational aspect and undertake research and come up with facts and figures. So that by the time we come and face the HMOs or providers, that this is what we have seen. It cannot be controverted. So we confront them. We now inform them that this is what we obtained. If you have any contrary opinion, bring it up. So we have a superior information. And because of this problem, we are taking this course to correct it. And you have to support the process of correction. In fact, in the last meeting, last week we held a quarterly meeting with HMO. We told them that we want to see a situation whereby, I want to see a situation whereby only credible health maintenance organizations operate within the system. And I was mooting the idea of consolidation. Those HMOs that cannot work, we had an era when a banking consolidation was done, where banks were merged to become stronger. Right. So true. I informed them that if there are HMOs that cannot meet up with responsibility, I will not hesitate to seek for ministerial approval to do merger and acquisition, so that we can have HMOs that can be stronger to perform their stewardship role.
Professor Sambo, obviously there's so many things that have been happening, and some new things as well. And let me just quickly, before we round up, go on to a new concept that is built to take root in Nigeria today, which is described as the National Emergency Medical Service and Ambulance System. Yes. Completely new to Nigeria, even though this has been operating in many societies. How will the NHIS, being seen as a critical stakeholder in healthcare, what role would it perform in this system?
I think this is one of the programs that our President and our Honorable Ministers must be commended for. Because whatever you do in terms of building hospitals, in terms of providing logistics, if you don't arrest emergency, you will not be able to reduce the burden of all the mortality that is happening in our society, because road traffic accident is one of the most leading cause of mortality in the country. Therefore, any efforts by the Ministry of Health to bring about a system that can respond to emergency is very, very commendable. So I think they should be given kudos for that. The emergency medical treatment is one of the arm of the Basic Healthcare Prohibition Fund, because the argument is that if you have a very good primary health care, you have a secondary health care, you also have an effort to revamp the tertiary health care, and you neglect emergency system, you will continue to record mortality. And in emergency, what is critical is how soon will you be able to bring attention, to bring about support when the emergency happens. And if there is a delay in evacuating people from the scene of the emergency, like say road traffic accident, if there is a delay in conveying them to hospital, a lot of mortality will be recorded. And if there is a delay, assuming they are quickly evacuated to the healthcare facilities, and there is a delay in getting response by the healthcare providers, there will be another mortality. So you have to walk along all the chain to ensure that there was no initial delay at the point of the occurrence of the emergency, and there is no delay when a patient or a victim is brought to the hospital. That's why these names has came in. It is an emergency and ambulance treatment. There are ambulance system, whereby there will be ambulance system to convey, and within the system, anybody that has become a victim of emergency will be attended to immediately in the hospital.
All right.
So the relationship with the National Health Insurance Scheme, we have a very good history of registering healthcare facilities, having a collaboration with them, having a partnership and business arrangement with them. We have their profiles. We have the profiles of all the healthcare facilities in the countries. We know we have the profile of their directors. We have the profile of their services. So the emergency, we are partnering with the NEMSAS.
Okay, so you can supply this information to NEMSAS.
We supply them information to them, and we have a very good system of payment system to healthcare providers. So this is where we will interface, because NEMSAS is a program under the Ministry of Health for them to now create a structure that will be able to do a payment system. It will take a very long period of time, and it will amount to duplicity. Since we are deploying an overarching ICT, which is state-of-the-art, meeting international standard, we can use that channel to ensure that payment through NEMSAS is seamless. Then secondly, after the initial 24 hours, or 48 hours of resuscitating the victim, then we will now discover if he is an NHS client, then we take over the management.
Professor Sambo, all too soon, the time is up again. 1 hour is gone.
Yeah.
And this has been an interesting discussion. A lot more has happened in the NHIS. And once again, we'd like to thank you for taking time to talk about these things. We thank you. This conversation will have to leave here and hopefully continue at some other point in time. Thank you very much for being here once again.
I look forward for coming again.
Thank you. And that's our program today with Professor Mohammed Nasir Sambo, Executive Secretary of the National Health Insurance Scheme, NHIS. Next week, we'll be back with One-on-One. I am Cyril Stober, and I say continue to stay safe.